So have you ever thought about a medical condition that's so good at hiding, almost like a master of disguise in the body?
Ah, you must be talking about infective endocarditis, i.e.
Exactly, i.e. Today we're doing a deep dive into this enigma. It's known as the Great Mimicker for a reason.
That's right. It's a really serious heart infection, and yeah, it often hides in plain sight. Makes it incredibly challenging to diagnose.
So our mission today really is to unpack what your sources tell us about its subtle signs, the diagnostic maze, and the tools that finally bring it to light.
Precisely. We'll look at how to actually spot it.
Okay, so let's start there. What makes IE such a medical riddle? Why is it the Great Mimicker?
Well, the really insidious part, right, is that it doesn't just mimic one or two things. It can look like, well, a whole range of stuff.
Like what, for example?
Your sources mention rheumatological issues, neurological problems, autoimmune diseases, even certain cancers sometimes.
Wow. So that could easily send doctors down the wrong path initially.
Absolutely. It often delays the right diagnosis, which can be critical.
And it's not always that dramatic high fever infection we might picture.
No, exactly. I mean, sometimes it is that really fast acute infection, sure, but often it's much slower, subacute or chronic. Maybe just a low-grade fever or sometimes no fever at all. And really non-specific symptoms, like just feeling tired all the time, general malaise.
That sounds incredibly easy to overlook then.
It is very easy.
What about those sort of classic textbook signs like Roth spots or splinter hemorrhages under the nails? Are they reliable clues?
Well, they are associated with IE, things like the Roth spots, those little bleeds in the retina, or the splendour hemorrhages. But the surprising thing from the sources, their overall reliability, their sensitivity and specificity, it's actually quite low.
So you can't hang your hat on them.
Definitely not. Their absence absolutely shouldn't rule out IE. You often only see them later on, or in more severe cases anyway.
Okay, so if the initial signs are tricky, where do doctors even start to get a firm diagnosis? What's the basic roadmap?
Right. The foundation, really, it's got to be blood cultures.
Okay.
And the protocol here is super specific. Get 3 separate sets of blood cultures, aerobic and anaerobic, in each set about 10 milliliters of blood. And crucially, before starting any antibiotics. That timing is key.
Makes sense.
Yeah.
And anything else about drawing the blood?
Yes. And this is really key. The sources emphasize always using a peripheral vein, like from the arm, not a central line, even if the patient has one.
Why is that so important?
It's all about minimizing contamination risk and avoiding potential misinterpretations from bacteria that might just be on the catheter itself.
Got it. That's a vital detail. Now, if someone has IE, is the bacteria constantly in their blood? Can you draw the cultures anytime? Yeah,
generally in IE, the bacteria in the blood, it's constant, so you don't necessarily need to wait for a fever spike. When that bacteremia is active, usually all 3 sets of cultures will come back positive. It's a pretty consistent clue when it works.
But what if they don't come back positive? What if the cultures are negative? That must make things really tough.
Right. That happens. It's really frustrating. And we call that blood culture negative endocarditis, or BCNE for short.
And the main reason for that is?
Most often, prior antibiotic use, someone took antibiotics before the cultures were drawn.
So what do you do then?
Well, if the patient is stable, the recommendation is often to actually stop the antibiotics for maybe a week and then try culturing again.
Interesting. Are there other causes for BCNE?
Oh, yeah. Sometimes it's caused by what we call fastidious organisms, basically bacteria that are really hard to grow in standard lab cultures like Coxiella or Bartonella.
So you need different tests.
Exactly.
Yeah.
More advanced tests like PCR, looking for the bug's genetic material, and sometimes it's not even an infection causing the valve issue.
Really? Like what?
Could be non-infectious causes, maybe autoimmune conditions, even malignancy in rare cases. That requires different blood work, looking for things like ANA or APLA antibodies.
So for those really tricky cases, the culture negative ones, how do you get the definitive answer? The gold standard?
Often the best way, especially when it's complex, is actually getting a piece of the tissue.
From the heart valve itself?
Yes. Surgically removing the vegetation that's the infected growth, or maybe even a tiny piece that's broken off and traveled elsewhere, an embolus. Then you send that tissue to the lab for detailed analysis, histopathology. That usually gives you the answer.
Okay, that makes sense. So we've talked about how it hides and the blood tests, but seeing inside is crucial too, right? What about imaging?
Imaging is absolutely paramount. Echocardiography, echo. That's usually the starting point.
The ultrasound of the heart.
Right. You typically start with a transthoracic echo, the TTE, done on the chest wall, if that's negative or maybe unclear.
Then you go to the next step.
Then you move to a transesophageal echo, the TOE, where the probe goes down the esophagus for a much closer look at the heart.
And that TOE is particularly important for certain types.
Yes, definitely better for infections involving prosthetic, artificial heart valves or cardiac devices like pacemakers, PVIE and CIE infections.
Now, I heard something interesting about that. Even if the first scan, the TTE, looks positive, is it sometimes still better to do the TOE?
Yeah, that's a really important point. The thinking now, based on these sources, is actually to lean towards doing the TOE pretty much always, even if the TTE already showed something.
Why is that?
Because the TOE is just far superior at spotting the really critical complications around the valve. Things like detachment, abscesses, or fistulas, abnormal connections. A TTE can easily miss those.
Okay, that's crucial information. And you might repeat echoes later on, too.
Oh, definitely. If new complications are suspected, or maybe when switching from IV to oral antibiotics, and just for follow-up to see how things are healing.
Makes sense. What about imaging beyond echo, things like CT scans or MRI?
They each have their role. Cardiac CT is really useful, both for diagnosis and spotting complications. It can actually be more accurate than TOE for detecting any abnormality overall.
Oh, interesting.
Though TOE is still better for seeing the really small vegetations. CT is also great for finding related problems elsewhere in the body, distant lesions, and for planning surgery.
And MRI, where does that fit?
MRI really shines for looking at neurological issues. If there's a concern about stroke, brain hemorrhage, or abscesses in the brain or spine, which can happen with IE, MRI is the go-to.
Gotcha. And what about nuclear imaging, like PET-CT scans?
So PET-CT is especially valuable, the sources say, for prosthetic valve endocarditis, more so than for native valve infections.
Why the difference?
It's about how the tracer, the FDG, is taken up. It tends to accumulate differently around infected artificial material compared to infected natural tissue. PTT is also really good for finding those hidden pockets of infection elsewhere in the body, and even for tracking how well the treatment's working over time.
Wow. So putting it all together, diagnosing infective endocarditis really demands, well, a sharp clinical instinct, plus this very specific multi-step diagnostic plan, doesn't it?
It absolutely does. It's complex. It shows how much careful thought and, frankly, sophisticated technology is needed to unmask this kind of condition.
It's a real testament to how infections can be masters of disguise. It really makes you think. In a world where conditions like IE can hide so effectively, what does that imply about where medicine is heading? About our need for even smarter diagnostics, more personalized approaches?
That's a great question. Definitely something to ponder.
Something for all of you to chew on until our next deep dive.